good evening, all the students. Hello, dear students. Assalamu alaikum. Good evening. How's everyone? We are here to discuss fetal physiology. I have written this thing that read the fetal circulation notes first. For the fetal circulation, we also have a free webinar which is already recorded and given on the YouTube for free, so you all can follow that also. Why this is important to read the fetal circulation first? Because first thing, we are always working on the past papers. We're always interested in knowing that what examiner can ask. And we have many questions from fetal circulation. So I have conducted a class already and information is already given about it. Further, guys, you will learn the names of the shunts and the functions of the shunts in fetal circulation part. For this specific topic, if someone contacts Medicurics team, I will provide this file for free, which is only available for the course students. But this is an important topic from the physiology, and we are here to help all the students, either they are taking our courses or not. So what we do, we provide them free support in every possible form. So today we will cover cardiovascular and respiratory physiology. In this session, we will quickly cover it in 20 minutes, inshallah. And guys, what you will do, you will get the file from by contacting Medicurics team. There is a certain way they ask for an identification and your medical registration number before sharing anything. So you have to provide your details and get the file. Because this file is having very important information regarding this topic. I've also told you that in the physiology, if they ask very basic questions from the normal person's physiology, that's a part of your MRCOG 1. But these two topics, maternal changes, okay, maternal changes, these are very important from all the systems. I have shared the notes already, and I have given you very brief and very concise notes, and they are about CVS changes in pregnancy, GI changes in pregnancy, respiratory changes in pregnancy, and which is reduced and which is not increased and which remains the same during pregnancy, endocrinology during pregnancy, we have already shared, and I have shared that very important topic that what are the changes occurring in the mother when she is going through a pregnancy in um, that clotting cascade, and very important one, hematological changes. Okay, so all the topics related to maternal changes are very important. Second, role of fetus. Okay, fetal physiology, which we are going to discuss today. This is an also very important topic. We have question. Okay. Yes, recording of this webinar will be shared, and the one I'm talking about is already shared on the YouTube. You can just go and write uh, cardiovascular changes in the pregnancy or fetal circulation, and you will find that. So let's start. Fetal cardiovascular physiology. Fetal heart and cardiac output. We need to understand that what happens. The circulation begins at the week 4 of the gestation. And it is very important to answer this question that which is the first system which is functional in a fetus or embryo. Can you name that? Is this CNS? Is this CBS? Is this any other system, renal or what, respiratory? Can you answer this question? Good. This is CBS. So the first system which is going to begin in a fetus is this. Guys, please do not use your screen or don't draw anything, okay? Don't draw anything on the screen. Blood bypasses lungs through ductus venosus, foramen ovale, and ductus arteriosus. And again, I will tell you that learn the functions of all three shunts. Learn the function of all three shunts by reading that notes I have given for fetal circulation. This is very important that you should know the location of the shunts and function of the shunts. Location and function. Cardiac output is termed combined ventricular output. Why? Because right and left ventricles, they don't pump equal volumes. They're not equally pumping the blood. So 2 by 3rd from the right and 1 by 3rd from the left is pumped. This is important. Fetal myocardium grows through hyperplasia, cell division before birth, and after birth, we have hypertrophy. Fetal heart muscles contain fewer contractile fibers, 30%, and in the adults, we have 60% contractile fibers. It is less compliant, you can say less flexible, with limited ability to increase stroke volume. Cardiac output increases mainly by increasing heart rate, not the stroke volume. What about cardiac metabolism? Let's see. The fetal heart uses lactate and carbohydrates as the primary energy source due to the lack of the enzymes for fatty acid transport into mitochondria. Okay. Now, which is very important thing, fetal heart rate. And as a gynecologist and obstetrician, you should know that heart rate is very important in determining if the fetus is doing well or not. Anything we want to know about the fetus is checked by checking the heart rate. If fetus is going well, if fetus is doing well, if fetus is not doing well, we have to understand this thing by getting a heart rate. We know how we can get the heart rate. First thing is the device which is in your hand mostly during the practice. We call it Sonicate or Sony 8. So you can get a good number of beats from a fetus. Other thing we use is the cardiotocography machine. Very sorry. So the heart rate is determined by SA node under control of both sympathetic and vagal. Sympathetic stimulation, it increases the heart rate of the fetus and vagal tone decreases, so it will keep a balance. Now, epinephrine, some drugs, and temperature of mother can affect the fetal heart rate. There is a role of baroreceptors and chemoreceptors in the fetal circulatory system. It also influences heart rate via blood pressure and oxygen levels. What are the gestational changes in the FHR? Again, a very important topic. Parasympathetic maturation is playing a very important role. When gestation advances, when there is a more mature fetus and it's close to term or close to birth, parasympathetic activity increases. Parasympathetic increases, causing a gradual decrease in FHR. So we know that we're taking a patient with the 7 months old fetus, 7 month of gestation fetus, the heart rate will be increased, and close to term, the heart rate will be lower. But we have a baseline. We have a baseline near the term. We use this baseline, which is 110 to 150 or 160. Some books say 150, some books say 160. We try following 160 here. And more than 160, what we call it, and below 110, what we call it? Can you name it?
Tachycardia above 150, bradycardia below 110.
Well done, well done. So we want to know why a fetus show tachycardia and why a fetus show bradycardia. We want to know this. So we have this answer here. 10 minutes or more, we get this reading. We call it fetal tachycardia, and why it happens due to hypoxia, maternal fever, chorioamnionitis, drugs, or fetal heart abnormalities. And when we have bradycardia, we can look into some causes again, and that causes are again a hypoxia, cord compression, placental abruption, or other stressors. Fetal heart block is a very rare cause of persistent bradycardia. It will not recover by any treatment. What are the transitional events we find at birth? Firstly, loss of placental circulation. What happens when the placental circulation is cut off? That means fetus is not getting any supply from the mother. So the fetal shunts between the pulmonary and systemic circulation. Firstly, we did not have any pulmonary circulation or the role of lungs in providing the oxygen to the fetus. Everything was given by the placenta. When the placental circulation is cut off, then these shunts somehow need some changes. So, which shunts are closed? Ductus arteriosus, foramen ovale, and ductus venosus. They close. They close and they now work as a different pulmonary circulation and a different systemic circulation. What happens? Heart's output is now measured like an adult. Okay. And what are the myocardial changes? There is a rapid increase in contractility and left ventricular mass is also increased because left ventricle starts handling systemic circulation while the right ventricle manages the lungs, just like an adult. We have a metabolic shift as well after the birth. Lactate and carbohydrate metabolism is switched and it's more relying on free fatty acids as the primary energy source for the myocardium, which is more efficient in the oxygen-rich postnatal environment. Now, what happens to umbilical blood flow? We have fetal-placental circulation in a fetus and how it is controlled. So from the fetus to the placenta, we have umbilical arteries. From the fetus to the placenta. Who will tell me what umbilical arteries carry? Which blood? Oxygenated or deoxygenated? We want to clear the deoxygenated blood from the fetus, and there is only one way we can use only the placenta for this purpose. So umbilical arteries are carrying deoxygenated blood or oxygenated.
Deoxygenated blood.
Very nice, very nice. And umbilical veins, which are giving oxygenated blood from the mother to the fetus. So, firstly, this is very, very simple and yes, good. It's very simple point. It is in mind, or you don't recall this point frequently, you can make mistake while solving a question, which is very simple. So they are giving you an approximate number, percentage you can say, 33% of cardiac output at 20 weeks and 20% after 32 weeks. These arteries are getting. When the fetal growth is ongoing, umbilical blood flow is also higher and it's lowest in 41 weeks when normal fetal weight is achieved. Placental blood flow has no neural regulation and catecholamines have very little effect on it. Okay. So neural regulation, parasympathetic or sympathetic regulation was true for heart rate only, not the blood flow. Then how we control it? Tonic adrenergic influence, mainly vasoconstriction, is the primary regulator, and it is somehow through the norepinephrine. Arginine, vasopressin, and RAS system and prostaglandins also have a few roles. Beta and chemoreceptors ensure increased blood flow to vital organs, brain, myocardium during hypoxia by redistributing blood flow, particularly important in fetal growth restriction and monitoring. How fetus meet oxygen needs. How fetus meet oxygen needs. We will discuss this now. Due to mixing of both bloods, oxygenated and not which one, the one which is oxygenated. In the just a minute, please. Oxygen content in the fetus is lower than the postnatal life, or you can say after birth. Oxygen is lower in the fetus. So how we ensure adequate oxygen delivery? there are shunts. Preferentially deliver oxygen-rich blood to the brain and myocardium. Okay, you can see the purpose. One purpose of the shunt is this: shunting of oxygen-poor blood to placenta for oxygenation, and high heart rate and fetal hemoglobin binding oxygen capacity. It is very efficient. Even at low oxygen levels, fetal hemoglobin has this higher capacity for catching the oxygen and providing to two very important organs, brain and myocardium. So what we are shunting here, shunting or is this blood is escaping from liver and lungs. Okay, so the fetal circulation is all about escaping the oxygenated blood from liver and lungs. This is the important point. So what happens after birth? The low resistance placental circulation is lost, causing systemic resistance to double, increasing pressure in aorta, left ventricle, and left atrium. Lung expansion at birth after taking the first breath leads to pulmonary vasodilation and reduced pulmonary resistance. What happens? Shift from parallel fetal circulation with placental respiration to a series neonatal circulation with pulmonary respiration. Okay, placental respiration is now finished, and we have now pulmonary respiration after these events. And if you are not done with this thing, I've told you that fetal circulation lecture is already shared. And the further this ductus arteriosus closure, ductus venosus, and foramen vein closure is discussed there. But firstly, you should know their function. Okay, firstly, you should know their function. So we are skipping this part so that you can complete that topic um, from the YouTube lecture. And now we're starting fetal respiratory system. Guys, this table was considered not so important in past years, but a year back, we had two questions only from this table in from the fetal physiology. So I have given this table from Essential Revision Guide. You can see this is very easy to memorize by just keeping this 7 number in mind. You can see 7, 7, and if you learn this also, like 36 to 37 weeks is the time of birth, you can easily remember all the stages. Conception to 7 weeks, we have embryonic stage, 7 to 17, pseudoglandular, 17 to 27, canalicular, and then 27 to 37. If you want to memorize this way, this is saccular, and then alveolar, 2 years post birth. Okay, what happens? We have formation of main bronchi and bronchopulmonary segments first. We have, I have shared a very good picture. I have shared a very good picture in the file of the embryology. Okay, in the embryology section, I've already discussed the thing, but this is also a part of fetal physiology, the lungs of the fetus. So I have shared the table again here, but you can go through the notes of the respiratory embryology from the embryology section. Now we have branches of airways and blood vessels forming the conducting airway system of the lung. SNI and gas exchanging parts of the lung in the canalicular phase. This was the question. This was the question in the exam. Enlargement of peripheral airways, thinning of the airways to form the terminal sacs, and definitive alveoli. This was also the exam question. Okay. So canalicular, we have gas exchanging parts, and alveoli when we have alveolar stage, definitive alveoli, which are able to which are able to perform the function by exchanging the gases. Now we're talking about the embryonic phase. Outpouching of the ventral foregut gives rise to lung bud. Lung bud divides into two bronchi, further subdividing into Tracheobronchial tree. Pulmonary arteries develop from the sixth aortic arches alongside airways. Okay, I've told you many times that read things like a storybook. You can see if we keep following with our maximum interest, this is like a story. There was a bird, we call it lung bird. From where it's coming from ventral foregut. And then this lung bird is dividing into two because we know in an adult we have two lungs. So definitely one bird is giving two lungs. But there is a procedure. And we also know that in the lungs we have collaboration of arteries. So those are the pulmonary arteries. And pulmonary arteries coming from where? Sixth aortic arch. It's very easy to memorize. When you learn the things like a story and you keep your brain cells very alive. Okay? Logically, uh, if we think we are developing very good concepts just by reading the things like a story. Then we have branching of airways and side by side blood vessels are also continued. By 16 to 17 weeks, branching is complete and total number of airways, pre-acinar airways will not change. We have canalicular phase and again terminal bronchioles, alveolar ducts, primitive alveoli, which will become gas exchanging structures. Saccular walls will be thin, peripheral airways enlarged, forming terminal sacs to increase lung surface area, alveolar formation of definitive alveoli. And it will continue postnatally. What about fetal breathing movements? They begin at the end of first trimester. Everything which is highlighted or written in bold letters or written in this way is your exam question. It is given in the previous past paper, so I have highlighted this way. Now, breathing movements, they increase in the strength and frequency. Thought to regulate lung growth by controlling lung fluid and cell growth. Increased fetal breathing movements observed after maternal meals, glucose administration, and conditions of acidosis also. Decreased by fetal hypoxia, maternal consumption of alcohol, and sedative drugs. Okay, so fetal breathing movements are there. Breathing movements, not actual breathing like adult. What are the lung fluids? They're formed by alveolar epithelial cell secretions started during the canalicular stage. Can you see that in the table as well? Lung fluid is essential for normal lung development. Lung hypoplasia may occur if fluid levels decrease or there is an absence of amniotic fluid. We have a very important point now in the respiratory physiology, which is the production of surfactant. Okay, surfactant production is also a very important thing. From where it is produced, type 2 pneumocytes, again, I'm telling you that this is a past paper question. That from where surfactant production occurs, this is your past paper question. During late gestation, it starts producing. So whenever we have a premature baby, what we try to do? Tell me. We have a premature baby and we think that it is in the lung development phase. In that phase, we don't have good surfactant production.
Dexamethasone injection, I guess,
Very
before
nice.
delivery.
Surfactant
I am
injection.
Very nice. So this is the part of the management where we have this threat. We have this threat from the patient and the fetus that it can the girl, the mother, she can produce the baby premature. So what happens? We give her some glucocorticoids, betamethasone, dexamethasone, we call them steroids, and they help production of this surfactant from the type 2 lymphocytes. Now, what is surfactant? It is 90% lipids. From this 90%, we have two-thirds being DPPC and 10% proteins, including A to D surfactant proteins. What are the functions? The name is suggesting it reduces surface tension. Okay? It lubricates the airway. Simple. Increase pulmonary compliance. When it lubricates it, we have good compliance, and we don't find any kind of collapse in the lungs because of this surfactant. Proteins B and C aid surfactant spread over alveolar surfaces. Surfactant protein A and D play a role in the innate immunity. And again, beta-methasone, dexamethasone accelerate the surfactant production and lung maturation. Delayed lung maturation is seen in maternal diabetes and male infants due to androgens, but these are not very common conditions. What are the transitional events at birth in the respiratory system? Again, the respiratory system and circulatory system, they both are, connected. All the time, I'm making this effort while making the notes or making the lectures. I try to connect the topics. If you are reading the CVS and you are reading the respiratory system side by side, if you are learning the CVS, that CVS is giving you a very good support when you are reading the respiratory system physiology because they are interconnected. And the same thing we did in the previous module with anatomy and embryology. And I want to ask this question to Dr. Redin. Dr. Redin, you have joined the group and probably you have received all the files. Have you got the recording of your previous module?
No, I haven't recorded any recording. I've just get the file of physiology and embryology, physiology of male reproductive part and the female reproductive part.
Okay, okay, I will look into this. Right
I'm
after the
not
lecture, I
getting
will
any
look into
file.
it. Okay, okay. I'm looking into this. And you will also get the recording of the previous session we conducted for
Thank
embryology
you so
and
much.
don't
Mm,
worry about it.
Okay,
Okay, so
thank you.
before birth, okay, thank you. Lung fluid secretion decreases and reabsorption begins. At birth, the first breath creates an air-liquid interface facilitated by surfactant, which we just studied. Most lung fluid is absorbed within 2 hours after breathing begins. Okay? First breath generates pressure 10 to 15 times greater than those needed for subsequent breaths. First breath. Okay? Once the lungs are aerated, breathing becomes easier with negative intrathoracic pressure required to maintain normal tidal volume. More important are the serious changes at birth. I've hardly seen any question from this part, but I wanted to complete the notes, so I have given this. Now, whenever you are delivering a baby, you all are obstetricians. Whenever you are delivering a baby, you will keep this birth transitional events at birth in your mind, and you will use this knowledge. For the guys, we have fetal hematology, immune development, renal physiology. Renal physiology is very important. Just gastrointestinal physiology, very important one. Then we have nervous system physiology, fetal, physiology of amniotic fluid and fetal pain. All these things are given in this file. This file is with the core students. And if you are not a core student, you can just go and request Medicurix team or you can text me for this file. I will send it to you and you should read it because this is a very, very important part of physiology. We have discussed 2 sections and other sections you will read yourself. Okay, dears, any question about today's discussion? Thank you so much. I will meet you in another webinar which will be conducted right after Eid, inshallah. Okay, then you will get all the files. All the files, okay? Let's finish this session. Bye-bye.